Thank you for joining us for today's webinar. My name is Karin Shaw, and I'm a member of the Alumni Affairs Office in the School of Public Health. What we hope to do with this program is to open the classroom, to introduce you to some of our faculty members, and to keep you abreast of the latest research and thinking on critical public health issues. These webinars are designed to be part lecture, part discussion. We want to hear from those of you practicing public health, so we will allow time for questions. If you have a question, simply type it in the chat window in the bottom left-hand corner of your screen. You can type them as they come up during the lecture or wait until the question and answer part of the webinar. Also, please feel free to give our speakers some feedback using the emoticons. For those of you that just joined, please set up your audio by going to Tools and select Audio. Our webinar today is on nurse staffing and hospital mortality. Appropriate nurse staffing in hospitals has been a contentious issue because nurses are the largest single cost for hospitals, and the levels needed to keep patients safe are hard to determine. In this webinar, Dr. Jack Needleman reviews his recent research on staffing and mortality and discusses the implications for keeping patients safe. Dr. Needleman?
Good morning. Thank you very much, Karin, for the introduction. I look forward to our conversation as the webinar goes forward, and I'm truly delighted to be here. For the past decade, I have been working on issues of improving quality of care in hospitals, and a substantial amount of that work has involved looking at issues of adequate staffing, particularly nurse staffing in hospitals. That's what I'm going to be talking about today, but my intention is also to try to put it in the larger context of the evolution of the health system and the challenges of delivering safe and reliable care as we move into the next decade. Part of the context for this discussion, of course, is nursing, since I'm looking at nurse staffing. And it's important to remember nurses are the largest healthcare occupation in the United States. There are more than 2.8 million nurses in the U.S., and over 2 million of them work in hospitals. So the hospital is a centerpiece of nurses' work, and it's where patients go in to be well cared for with concerns that they get care that is safe and reliable. Nurses are involved in all aspects of that care. They deliver ordered care, and that tends to be the way we think of nurses, but their involvement in care goes far beyond that. They are key participants in the care team, assuring that care is coordinated by the other members. All the other care that patients are receiving is coordinated. That coordination task falls heavily on nurses. They are actively involved in monitoring and assessing the patients that they're caring for, determining whether their healing is one would expect, whether they are looking like they need additional care, looking like they're developing complications, and the nurse is the first line in assuring that those complications or threats to the patient health are actively intervened in. And they're involved in patient and family education and advocacy for the patient with the hospital, with other staff members, with physicians. The work of nurses is physically demanding, it's emotionally demanding. I think people understand that. It's also intellectually demanding. That issue of dealing with monitoring and assessment and constantly evaluating whether the care that's been ordered makes sense for this patient as a double check on that care it's an intellectual task that I think people often fail to recognize in the work of nurses. It's also managerially demanding. Nurses are typically assigned 4, 5, sometimes 6 or more patients on a shift. If you're working in an ICU, much sicker patients, you may be assigned 1 or 2, sometimes 3. and the ability to manage all the work that needs to be done for all those patients. And as it constantly changes, as patient conditions change, as new work is ordered, as things get out of the order that people originally expected, is managerially demanding. So that too is often underappreciated about the work of nurses. So physically, emotionally, intellectually, managerially demanding work, in order to assure it gets done, there have to be enough well-trained nurses. We've gone through many periods of where there's been stress on the hospital finances and therefore the number of nurses that are employed. The next decade is going to be a decade of bending the cost curve and searching for value in healthcare. Bending the cost curve, searching for value, that sounds very neutral. It's going to be a new era of efforts to contain the growth of healthcare costs, if not, and we're putting substantial pressure on institutions. One of the last times we did this in a heavy-handed way, the late 80s and early 90s, the Hunter Group, as the epitome of one of the groups that was working with hospitals, was notorious for walking in and simply recommending cuts in staffing. So we can talk about the Hunterization of cost containment. And in that environment, nursing was looked upon as a cost center rather than a service line. And as Karin alluded to at the beginning, labor is the largest element of hospital costs, and nurses are the largest element of labor costs. If you're looking for places to cut costs, we follow the Willie Sutton theory and go look for the money, and the money is in nursing. So this became a major battleground in the 80s and 90s. Partly in response to that, nurses began pressuring government and others to assure that staffing would be adequate through regulation, through legislation. Part of this led to the request for the Institute of Medicine to do a study on nurse staffing in hospitals and nursing homes, the adequacy of it. And in the 1996 report that came out of that, IOM, somewhat shockingly, I think, to people in the field, said there's an absence of clear evidence of value of nurses. They said, we believe there's evidence here, but when you look for the research base to support it, it is relatively weak. And this led to a whole series of new research, including two seminal papers, a paper that Peter Bierhaus and I co-authored in 2002 that appeared in the New England Journal of Medicine. Same year, Linda Aiken had an article, and her team had an article that appeared in the Journal of the American Medical Association, JAMA, both of which showed evidence of that in hospitals with low staffing, the rates of complications, adverse consequences for patients, and in some cases mortality, were higher. Other studies also were published during this period, and when the IOM did another report in 2003, Keeping Patients Safe, the Work Environment of Nurses, their conclusion about the state of the art of research was very different. They said there is strong and accumulating evidence that higher nurse staffing levels in hospitals and nursing homes result in safer patient care. Major turnaround, and one that quickly became part of the context for discussing nursing. And indeed, since 2003, there's been continued publication of more studies on the impact of nurse staffing and policy responses to the concerns of nurses as well as the evidence, including things like the California minimum nurse staffing requirements. I think there's also greater, but clearly not universal recognition of nursing as a service line, not just a cost center, which raises the question, why another study, and indeed, why this study, nurse staffing and inpatient hospital mortality, which was also done by me, Peter Bierhaus, colleagues at the Mayo Clinic, published in the March 2011 issue of the New England Journal of Medicine. Why another study? Why did we do this? Well, I think part of the reason we did this was despite the evidence that had been presented, despite the evidence the Institute of Medicine cited as growing and expanding evidence of the value of nurses in care, this continues to be skepticism. And some of that skepticism is because dealing with it will require assuring adequate spending on nurse staffing. So when you look at some of the comments and criticisms that have been made of our 2002 study, other studies that have been done, fundamentally the thing you have to appreciate is those studies compare low-staffed hospitals and high-staffed hospitals and say patient care, patient complications, adverse consequences, mortality appears to be higher in low-staffed hospitals. And while those are associations, because that's what research of this kind does, it's been treated as causal, and others have said not so fast. Maybe it's not the nurses and the staffing levels, maybe it's something else. Maybe those hospitals that have lower staffed, that are lower staffed in their nursing have poor quality nurses or poor quality doctors or less commitment to quality. Maybe they have less technology. And it's those things, not the nurse staffing, that are explaining the differences in these adverse consequences, these complications, and increased mortality. So that's one of the things that needs to be resolved in order to have people move forward with consequence. And that was a major motivator for the study. There were other issues with those studies. The nurse staffing measurement in them is very imprecise. We used average annual staffing with some adjustment for inpatient and outpatient staffing because we wanted to focus on inpatient care. Linda Aiken and her team tend to use a one-time survey of what was the staffing like on your last shift. So it's not clear what staffing levels individual patients got exposed to, and that creates imprecision in the work. Another issue with these studies is the lack of adequate adjustment for patient nursing acuity. In some hospitals, the Mayo Clinic, UCLA, New York Presbyterian, Mass General, patients are very sick. They need a lot of nursing care. Some of that's reflected in which units they're on, in an ICU, in a med-surg unit. But even on med-surg, and even in ICUs, hospitals with the sickest patients need higher levels of staffing than the average. And in hospitals with less acute patients, they may be able to get away with lower levels of staffing than the average. So we have not been in this research able to do adequate adjustments for patient acuity, and that becomes another reason for arguing maybe the low staffing, high staffing comparison is overstated in this data. And finally, I think the research that we're looking at here does not reflect an intuitive sense of what being short-staffed is. Yes, I can look at a hospital that has low average staffing and say, I'm not sure I want to be in that hospital. I am concerned that I will not get the nursing care I need. But the real vision of staffing is who are the patients in this hospital, indeed in this unit? How sick are they? How much nursing do they need to deliver the care that's been ordered, to keep them safe, to assure that the patient coordination is done, to assure that nurses can get their work done? And is the staffing level consistent with what is needed? That, to me, is the intuitive sense of being short-staffed, that the staffing is not adequate to meet those demands on the nursing staff. And it was an effort to look for ways to actually measure that became one of the major focal points for the research that we undertook. So what we wound up doing in this work was reconceptualizing the measure of short staffing, identifying a setting and strategy to test this new version of a measure, this new understanding of what short staffing is. I want to report a little bit on what we found and the implications for management and policy, because there are two environments that care about this kind of research. And then talk about where this work, with its study of an institution at a specific point in time, fits in terms of thinking about the long-term demands for changing how nurses work. So let's start with the alternative conceptualization and measurement. And as I said, my core vision of what short staff means is there's not enough staff for nurses to be able to complete their work. So it's the gap between the actual staffing and the staffing that's needed for nurses to effectively deliver their work, what we could call the target staffing for a given unit. So how do we get targets? Well, hospitals can establish staffing targets based upon their model of how they organize nursing care, based upon the census, how many patients do we have, and their nursing acuity, what their need is for nursing, and other factors that can influence the nursing workload. Patient turnover turns out to be a major issue because as new patients come onto units, as patients go off units, that's extra work for the nursing staff. A measure of staffing related to targets allows each organization to accommodate organizational nuances rather than fixed staffing targets that might be applied to all organizations. As I said, I suspect that if UCLA or the Mayo Clinic or New York Presbyterian or Mass General is staffing their med-surg units at the national average, they are understaffed because their patients are sicker. This is the challenge and the reason why I think hospital-specific, indeed unit-specific measures of target staffing or needed staffing provide a much clearer understanding of thinking about the adequacy of nurse staffing in units. So if the goal is to think about a target and measure short staffing, how can you address it? Well, in a research study, we addressed it by finding a place that had data on both targets and actual staffing. We decided and could tell you on any given day, for any given unit, on any given shift, what the target staffing was and what their actual staffing was. And they could also tell you for every patient in that institution, what unit were they assigned to at each point in their stay. So this enabled us to examine the association between patients' mortality and day-to-day, shift-to-shift variations in staffing at the unit level, and to identify individual patients' experience of low staffing. The institution that had this data, that was willing to provide it to us for this research, had lower than expected mortality. If you look at their patient mix, you would expect about a 3% inpatient mortality rate. They had less than 2%. They had high average nurse staffing levels. They had lots of sick patients. They staffed very high to manage that. And they were recognized for high quality by the Dartmouth Atlas rankings in the U.S. News and World Report. They are a magnet hospital, which says something about their nurse staffing system and the recognition it has received. The data that we got from them enabled us to include extensive controls for other sources of increased risk of death, the patient diagnosis and whether they were surgical or medical patient, how old they were, what kind of insurance they had, and other demographic information that's been associated with mortality. We also knew which units they were admitted to, which tells us, in addition to their diagnosis, something about the severity of their illness. We were able to take that into account when we measured the risk of mortality. It's a large tertiary academic medical center. We had lots of data. We had data on nearly 200,000 admissions to 43 units. And when you work it out, we had nearly 2 million patient unique records, which included information on the patient, what unit they were on, and what shift they were on. An incredible amount of data to move through. Any study like this requires a lot of data management, a lot of data merging. We had data on the patients from data abstracts and administrative support. We had data from the nurse staffing system on the patient classification and the targets. That system also records actual staffing data. We knew when patients were off the unit because they were in the surgical suite from another data set which records when anesthesia was billing the patients. So we had lots of information, including when the patients weren't actually on the unit, that enabled us to further adjust the staffing expectations for the unit. Lots of data. Key issue is, what are the measures of low staffing? We started with this concept of below target shifts. How far below your target do you have to be before the staffing could be considered low? An hour or two below target probably can be easily accommodated. We picked a standard of 8 hours or more below target. That was based upon a discussion with the clinicians. Turns out in this hospital, which does a really good job of staffing, very aggressive in trying to assure its targets are met, 16% of all the shifts had staffing 8 hours or more below target. That was slightly more likely on the ICUs, but you've got to keep in mind that ICUs tend to be bigger, the staffing is higher, so the average hours per shift were also higher. On the ICUs, the below-target shifts were distributed all through the day because staffing on ICUs tends to be about equal all through the days. It was more for the med-surg units, which tend to be staffed higher during the day. It was more, below-target shifts were more likely on the days and evenings, less likely at night. That's our definition of below-target shifts. We also discovered as we began, or as we reflected on the issue of low staffing, we realized that the staffing target system didn't take into account the fact that workloads would be heavier for shifts where lots of patients were coming on. They were being admitted or being transferred from other units, or lots of patients were going off. Both of those things increase the work of nurses. So we began thinking about the need to take that into account in our measure of low staffing. And we realized that units should be able to handle the usual amount of turnover on the unit, the usual amount of admissions, the usual amount of discharges, and a little bit above that. That's built into the staffing model. So what we looked for were shifts where the turnover was unusually high, either because there were an unusually large number of admissions or an unusually large number of discharges. And you can see on the slide here our very statistical definition of what we meant by unusually high. And we simply counted those. And those were about 7% of the shifts. Most were on the day shift because that's when most of the turnover occurs. That gives us the measure at the unit level of low staffing. We then need a measure of the patient exposure to low staffing, because fundamentally we want to ask what happens to patients and which patients are exposed to more below target or high turnover shifts. And the way in which we approach this was we simply were able for each patient to get a cumulative count of how many of those kinds of shifts were they exposed to. One of the issues we realized as we were doing this is the longer your length of stay, the more likely you are to be exposed to these below target or high turnover shifts. And patients that developed complications were more likely to be in the hospital longer, so they were more likely to be exposed to these things if we were doing raw counts. So we needed to take a measure that got some of that mismeasurement out of the measure. And the strategy we used a couple strategies. The one that I'm going to show some data on is to simply say, let's restrict our count of below target shifts to the beginning of the admission, the first 5 days. Average length of stay in this place was about 5 days. So the first 5 days covers what you might consider the normal length of an admission before discharges get extended because of in-hospital developed complications. We used some specific statistical methods that were particularly good for the kind of data we had, essentially allows us to measure the risk of, for each additional shift that you're exposed to that was below target or high turnover, how much did your risk of mortality go up over the baseline risk that you had given your condition and given the way the institution performs. So let me show you some data. This shows the patient exposure to below target and high turnover shifts, and then I'm going to show you some of the consequences of that for mortality. Here we've got our two of our measures of exposure. One is over the full admission, and the other is over those first 5 days. And even though the proportion of shifts that were below target was relatively low, 16%, and the number that were high turnover were relatively low, 7%, a fair number of patients get exposed to at least one of those. Over the full admission, only about 32% of the patients were exposed to no below target shifts, and only 40% of the patients were exposed to no high turnover shifts. You can see 20% of the patients were exposed to one below target shift, 13% two, 9% three. Then it tails off, but you get a few that are exposed to a great many. If you restrict yourself to the first 5 days, the number that were exposed to none go up a bit, but the numbers are pretty comparable. And in essence, the mean number of below target shifts our patients were exposed to were 3. The median was 1. The mean and median for high turnover was about 1 below target high turnover shift. So you're seeing some exposure there that's built into the average. But what we're comparing to is what happens to these patients compared to these patients, the one with no exposure. And what we found is for every below target shift the patient was exposed to, that's 8 or more hours below target, there was an increase in the base mortality of 2% over the baseline mortality. And for every shift the patients were exposed to with that were high turnover shifts, the baseline mortality was increased by about 4%. So with an average of 3 shifts that were below target, the average increase in mortality risk was about 6% over baseline. So the hospital had an average mortality risk of about 2%. We're talking about a bump up of mortality to about 2.1%. Does not look large, but those are sizable increases when you look at it relative to the other research that's been done. A 6% increase in mortality over baseline is about the amount that we see in the different studies between the low-staffed hospitals and the high-staffed hospitals. So the key findings on mortality, that 2% increase in risk for below target shifts, the 4% increase. We tried lots of different ways to make these go away, and the findings keep showing up. They're relatively robust. So our conclusion is even in a high-quality hospital that generally meets its targets and manages patient turnover fairly well, and with extensive controls for the influence of other factors that influence mortality, we could still detect effects of staffing and high patient turnover. What do I think are some of the... We've also been looking at other outcomes. We've got some preliminary results yet that haven't been published. One of the hot issues in the field is readmissions, because CMS, the Medicare agency, is threatening to stop paying for unnecessary readmissions. And we're seeing some evidence that readmissions are going up among patients for whom staffing in the last 2 days prior to discharge, the days when nurses have to do their work to prepare patients to take care of themselves at home or prepare themselves for care in a new setting. When in the 2 days when nurses are supposed to be doing that, if the unit's short-staffed, the patients that experience that short staffing are more likely to be readmitted. That's what our preliminary results are telling us. We also are looking at trying to understand the pathways for the mortality. So we've got a number of complications that we know are associated with increased risk of mortality. And we've been looking at the likelihood that those complications develop in these patients. And we're seeing that for 6 complications that make up this Agency for Healthcare Research and Quality measure of failure to rescue in their patient safety indicators, we're finding an association between increased risk rates of these complications and lower nurse staffing for 4 of the 6. So we're beginning to see the pathways by which mortality is affected by low nurse staffing. There are a great many implications of this for management and for policy. The most important one in my thinking about this study and how it's different from the earlier work that compared low-staffed hospitals to high-staffed hospitals is that if you were a high-staffed hospital, a high-average-staffed hospital, and reading that earlier research, you could feel comforted by it. You know, you look at some of the low staffing levels for average hospitals. For some of the hospitals at the low end of that distribution, say, thank God we don't look like that. We've got enough staffing to keep our patients safe. And that's probably true on average. But what this study says is there are no free passes for hospitals with high average staffing. If your staffing is high, in part because your patient needs are high, you need to strive to hit your targets every day, every shift. You're not going to succeed in that. Even really good hospitals, and the one we had our data from was a really good one, didn't hit the mark all the time. They hit the mark 84, 85% of the time. That's pretty good. But you need to strive to do that. If you're not even striving to do that, you don't get there. We also think that this study has clear implications for the hospitals that are less successful in routinely meeting their nursing needs for patients. Those patients, I think, are put consistently at higher risk. I think there is reason to be concerned for the hospitals that have low staffing, not because their patients are less acute, or even if their patients are less acute, but because they're simply not meeting, they don't have enough staffing to enable the nurse staff to get their work done every day. The California standards may be protective for patients at those lowest levels by not letting hospitals staff that low. But they could be too high for some hospitals, and they may be too low for others. This is one of the implications of this work. We need to find standards for staffing that are appropriate given the hospital, the way it organizes care, and the way in which the patients that they have. There are lots of operational implications for management. The first is, again, it reinforces this concept of nursing as a service line, not just a cost center. These nurses aren't busy delivering low-level, unnecessary, easily delivered care. They're a central part of the way in which hospitals keep patients safe, make sure the care that they deliver is reliably delivered. So that's one of the implications. That's a mind change. That's a culture change in the organization. But there's some very concrete operational changes that also need to be done. Hospitals need systems to accurately identify what their target staffing should be. They need systems for managing their staffing against those targets. They need to anticipate turnover, staff for it appropriately, and to the extent that staffing for day-to-day variations in turnover can be hard, they need to think about ways to smooth the turnover in these units so the demands on nurses are more evenly distributed. That, I think, are some of the key operational implications for the hospitals. There are lots of challenges of applying this within hospitals. One is, where do you get the standards for target staffing? What's the basis for setting the targets? Should we be concerned about the opportunities for gaming or lowballing? I'm going to set a low standard because I can meet it more easily. I think those are real issues for just setting the target. The other issue is, how do you know how far below the target should you be concerned with being? Is 8 hours the right number? Is it right for all units? I've done a little bit of additional work with some of the data we had. I think that 8 hours, because ICUs tend to be larger, they tend to have a lot more staff, A med-surg unit will often have 6 or 7 nurses on a shift. An ICU may have 10 or 12. 8 hours or more below target, 1 FTE down, looks a lot more difficult to adjust for in med-surg than potentially being down 1 when you've got a complement of 12 or 13 nurses on an ICU. So it may be that this 8 hours is not sufficient, is a little bit too aggressive a standard for ICUs, but we need to think about what it is. We need to think about how to incorporate patient turnover into our analysis of adequate staffing, and the systems that I've seen hospitals use don't do that. If you want to use this as a measure, you need to think about where you're going to be measuring it. Is it at the unit level or at the shift level? How many of our shifts were below target? Is it at the patient level? What is the right level for measuring? What's the right level for reporting? All these are very real issues, both setting the standards and keeping track of it. Some of the people I know, including myself, have been approached by hospitals to really move this research forward by looking at ways to operationalize both the targets and the measurement of adequate staffing in individual hospitals so that they can get it right. So that, I think, are some of the critical challenges to doing this and where a lot of the work is going to go forward. I'd like to see the validation of this work with the experience of other hospitals. I'm sufficiently confident in it that I don't think it's necessary to act on this work. But in order to convince me, or should be needed to convince others that we should be acting on this work, but validation is always nice for research studies. In terms of payers and implications for regulation, accreditation, payment, and reporting, as I said, we're about to enter an era of cost containment, aggressive cost containment, bending the cost curve. I think one of the clear implications of this research, along with the other research that's been done, is as we look for ways to encourage cost containment, look for ways to encourage bending the cost curve, or finding ways to increase efficiency in institutions, we need to assure that there's adequate staffing to keep patients safe and deliver care reliably. Minimum standards, I don't think, are going to be sufficient to do this because of the variations across hospitals. And it's not going to be enough to set the standards. We need to hold hospitals accountable for setting safe staffing levels and achieving those levels. Payment clearly needs to support and reinforce the ability of institutions to establish safe staffing. I think some of the initiatives around pay for performance, around not paying for never events, not paying for things that are influenced by the performance of the nursing system, will reinforce the need for institutions to make sure their staffing is adequate. But we need to think about how to really build that into payment. And we need to think about the extent to which we want to start building this into public reporting systems as well. That's where we are today, and all this research was based upon current levels of staffing and a current model for nurse staffing. But we need to think about the future, and I think for the future, we've got some major issues emerging. Over time, nurses' work will be redesigned, and our staffing models and standards are going to need to reflect this. And I think this is one of the challenges for creating a dynamic vision of what adequate nurse staffing is, rather than a static vision of it. Why do I think nurses' work is going to be redesigned? Well, I think 3 things are happening here. One is patients in hospitals are going to be sicker. Every opportunity that we can develop to move a patient out of a hospital and into some other setting is being taken. So patients that remain in hospitals are going to be sicker. Frankly, the patients that are being moved into other settings are also sicker because we're moving more acutely ill patients into those settings. So we're seeing sicker patients in nursing homes. We're seeing sicker patients in home health care. We're going to see sicker patients everywhere. But for the hospital, this means re-examining how their models of care work. Once this recession really ends, and I know nominally it's ended, but we're still in a tight situation, the nursing shortage is going to return, and we're going to have to think about how to staff against the prospect of not having enough nurses for our current nursing models. And finally, we're seeing lots of changes in technology in hospitals with both new opportunities and new demands. Excuse me for a moment. Electronic health records create new ways to monitor patients, but also new demands on staff to use new technology. We're seeing smart beds and easier, more routine ways to use telemetry to monitor patient conditions, and our nursing models are going to need to adjust to that. We're seeing models of what have been called electronic ICUs, heavily monitored patients, the use of more video camera technology, so the nurses can be present with the patient, even if they're not at the bedside, or at the risk of things being less present with the patient because they're not at the bedside. All of these things are going to require us to rethink how we deliver nursing care, and all that's going to be occurring in this environment of bending the cost curve, increasing the scrutiny on hospital costs. We know from some of the work that's been done on business case models for improving nurse staffing that I have done and others have done, that under the current payment systems and nursing models, increasing staffing to assure value for patients may not pay for hospitals. It is not clear that what is good for the patient is good for the hospital. And we need to think about redesigning the payment systems to produce better alignment there, but we also need to think about how to get even more value for patients out of the way we organize the delivery of nursing care. And because of the complexity of this work, nurses are going to need to be fully engaged in the redesign of the work. I talked about the managerial and intellectual complexity of nurses' work and the demands of that work. Frankly, the way in which we usually think about process improvement, which tends to be one compartmentalized problem at a time, is ill-suited to thinking about how to integrate better practice into the very complex, almost chaotic work environment that nurses work in. That's also going to require major changes in the way hospitals organize themselves to do process improvement work, including really thinking about how to build a culture of improvement that uses and engages the front line. I'm not going to go through my vision of what that is. I do think we have visions of what that work looks like and how to organize ourselves for doing it. But it's important to recognize that, and I'm just going to leap to the bottom point here, this is not just a matter of culture. If we expect the frontline staff and others who work at the front line, nurses and others, to actively engage in redesigning the work, reflecting on practice, and figuring out how to make it better, to figure out how to make effective use of the technology, we need to assure that they have the time and space and expectation in their work week to enable them and encourage them and indeed make as part of their regular work the improving of the work environment, not just delivering care within our current nursing system. So that's what I wanted to say today. We do have time for Q&A, and Karen, I'm going to turn it over to you.
Thank you, Jack, for sharing your research results and for showing the important role that nurses play and will play in the years to come in hospitals. I did want to mention at this point also that Dr. Needleman's research on the impact of nurse staffing and nurses' working conditions on patient outcomes in hospitals received the first AcademyHealth Health Services Research Impact Award. And also in 2007, he was inducted as an honorary fellow of the American Academy of Nursing. So we have about 15 minutes left for some questions. Please type them in the chat box on the lower left of your screen. And to give everybody an opportunity to ask questions, please ask one question at a time, and we will take them in the order they come in. While everybody is typing their question, I have a question to start us off. If a hospital isn't currently estimating its staffing at the unit level, what should it start doing?
It's a good question, Karen. First of all, we should understand that one option for every institution is to buy an off-the-shelf system. There are a number of vendors that sell systems for generating or for estimating appropriate nurse staffing. The hospital that we used in our research actually had one of the commercial systems, a system called Quadramed, and it works very well for them. It's somewhat intensive to enter the data, but it works well. And I think there are commercial systems to do that. A number of hospitals have their own homegrown systems that they've used. They tend to start with sort of what the average staffing should be given census on a unit, and then we'll make adjustments to that based upon day-to-day variations in the nursing acuity of the patients. The issue for those kinds of systems is the validation of the measure to make sure that the targets are in fact good measures of what your staffing level is needed, and thinking about ways to get feedback from the staff to make sure that's occurring. I mentioned that we've had several hospitals that have expressed an interest in working on this problem. We've got one hospital where the union in the hospital have suggested that we start again. How do we make the adjustments from the average staffing grid, the average staffing model that we have, and the nurse that assigns patients to the staff nurses is called a charge nurse in hospitals. And there's a sense that the charge nurse understands the staff and what they're capable of, understands what the patient acuities are on the unit, and if more staffing is needed for the unit, given who the nurses are, given who the patients are, that the charge nurse should be able to recognize that. So we're actually looking at a system where the staffing judgment about what adequate staffing is needed is going to be an implicit system rather than an explicit system, with the charge nurse being the central participant in making those judgments. So lots of different ways for an institution to approach this. They have to take the task seriously. Karin?
Yes, thank you. You said you did this research to better rule out some of the other explanations that have been suggested as to why adverse outcomes and nurse staffing are associated with one another. How well do you think you succeeded?
Well, when I was doing the presentation, I mentioned some of the stories, and I don't use the word story disparagingly. I think an awful lot of our research, we do all this research with data, and we show associations, but what we have underlying the reason for doing it is we have all these causal stories. We tend to tell stories, try to provide narrative explanations for what we're seeing. So the original narrative, the original story explanation of these findings was you need more nurses, because where nurse staffing is inadequate, patients can't be adequately cared for. The competing stories that we heard people put forward to explain the high staff, low staff hospital studies were, well, maybe it's not the number of nurses, maybe it's their quality, maybe it's the quality of the doctors, maybe it's the quality of the equipment, or the institutional commitment to quality of care, of which low staffing is only an indication. Well, this is, I think, the advantage of doing a single hospital study of an institution that has really good quality and is known to have really good quality. We had lower than expected mortality. We weren't just capturing, they're really good at keeping their patients alive. So these variations that we're seeing in mortality are not random variations because quality is uneven. It's the same doctors. It's the same technology. It's the same nurses. All those explanations that were put forward from the other studies, I think, are effectively controlled for in this single hospital study where we're able to look at things at the unit level and patient experience at the unit level. So I think we've done a pretty good job of controlling for those other explanations. at the risk of using a very inappropriate metaphor for study of mortality, I think we have put the nail in the coffin of the argument that it is not the staffing levels.
Well, it appears you've done a very good job answering the questions that the participants brought to the session, because I don't see any more questions from our participants. I wanted to ask you, Jake, is there anything you would like to add or ask a question to our audience?
That's an interesting challenge. It's a challenge I should never say no to. But I think one of the issues that I think the audience needs to think about is how this kind of research actually feeds back into their day jobs, into the work they're doing, the organizations that they are either working in, or to the extent that we have students in the audience, the organizations that they will be working in. As I said, I think there are several challenges here. One is the do we think the staffing is important challenge, and I think the research clearly addresses that. But the other is, what are the ways in which, the question that I would encourage the audience to think about is, what are some of the challenges of, what are the challenges in applying this kind of work in the settings that they're in terms of the administrative and operational challenges of getting the staffing right, the organizational culture, the issue of how it integrates with the financial goals and constraints on the institution. And those are some of the things that I would think about.
We do have another question from Hazel Peters. The question is, did your research include the use of support staff, meaning nursing assistants who manage non-nursing tasks like seating patients or performing baths or repositioning patients?
We had data on the support staff. We did not use it in the initial study, in part because some of the earlier work that we had done, including that 2002 New England Journal article, did not find a strong interaction with the staffing levels of the nursing assistants and the adverse outcomes we were looking at. Then this was a hospital that didn't have a very large number of licensed practical or licensed vocational nurses, so that kind of staffing mix issue didn't come up. We have the data. Down the road, with continued access to the data, I would hope to do the study to look a little bit more at what the potential protective value is of having more support staff, particularly on days when you're short-staffed in terms of the registered nurses, the licensed nurses. I think that's an important issue. I think as we move to more aggressive concern for issues like falls, where the support staff can be critically important, and as we frankly move nurses further away from the bedside through things like telemetry and electronic monitoring of patients, I think the role of support staff in assessing patients, calling attention to when things just don't look right, is going to be a critical challenge. And how we train people to do that is going to be a critical issue for these institutions. So we didn't look at it yet. I would hope to do it within the data we had. And I think more important down the road, what the role of these folks are and how they're integrated with the nursing staff more effectively in a nursing short environment is something that institutions are going to need to work on and struggle with over time.
You just brought up the topic of training, and I'm wondering, from your research, what are the insights in terms of where are some gaps, where is continuing education needed? And I know we have a couple colleagues from the School of Nursing that joined us, and I'm just curious to hear from you what your perspective is on the topic of training of nurses.
Well, as I said, I think this issue of as patients get sicker, the ability to assess and monitor patients, to think about how to where they are, what kinds of interventions are more appropriate, becomes even more critical. those critical thinking skills, the managerial skills, all need to be better integrated into nursing education. We need to think about how that the right mix of baccalaureate and associate trained nurses. There's a strong argument, given what I just said, for increased reliance upon the baccalaureate, but also we need to think about the content of baccalaureate education. I said one of the other things that I think is needs to happen is that nurses need to expand the vision of the work from not just taking care of the patients that have been assigned to them, but reflecting on the organization of reflecting on the practice of nursing in the units that they are working on, and identifying ways to strengthen that practice, to make the care better, to make it more patient-centered, to make it safer and more reliable. That's a different set of skills than simply taking care of the patients. And we need to make sure that nurses' education, either during their initial training or in training on the job and continuing education, that the skills to do process improvement work and actively participate in improving practice are being developed in the staff, so they're capable of meeting the need to participate in that kind of work redesign effort.
Well, thank you so much. We are running out of time. Thanks for continuing the conversation with us. If you have ideas for future webinars, please let us know. You can type your suggestions on the screen or email us. If you missed any of our previous webinars, just go to the School of Public Health website, ph.ucla.edu. They are all archived there. Please allow a few days for today's webinar to post. We will continue the conversation on Wednesday, November 16th with Deborah Glick. The topic will be shifting gears, how social media is helping redefine health and risk communication. The webinar is scheduled for Wednesday, November 16th at noon. We hope you can join us. Thank you and have a great day.